So this video is going to talk about what can go wrong when we're making our gastrointestinal tube. And there's a lot of things that can go wrong. In our next few videos, we're going to talk about pathology, and we'll start piece by piece. So we'll start talking about the mouth and the esophagus, stomach, intestine, and then work our way down. Okay? And we're going to talk about a lot of things that can go wrong when we're talking about those specific parts. But in this video, we're just going to talk about some few random tidbits that don't really fit in those videos. And let's start, again, proximally. So in this case, we're going to start with the esophagus. See what can go wrong during the development of our esophagus. We said the development of your esophagus is quite complex because not only do you develop your esophagus, the start of your gastrointestinal tube, but we also said that a bud comes out. And that bud will eventually make your trachea with its bifurcation, because your trachea bifurcates, and help develop your lungs. And then at the end of all that, it will separate. And that's good, because we want them to be separate. That is how you make your esophagus, that's how you make your trachea. Now what can go wrong? You can imagine a lot of things can go wrong. You can have your esophagus, have your trachea, everything seems to be going well so far. However, your esophagus will stop developing. We need it to keep developing, otherwise you won't be able to make the rest of your tube. If it stops developing, we call that esophageal atresia. That's a fitting name. And if you try and put food down here, what's going to happen is it's just going to hit that roadblock. Your baby will just spit it up because it can't go any further. You can have things like development of your tube, and then it'll branch off, start making your trachea as it should, and it makes it perfectly. However, it never separates. And if it never separates, then you have a connection, a fistula between your trachea and your esophagus. We call this a tracheoesophageal fistula. Tracheoesophageal fistula. Sometimes we call it a pair tracheoesophageal fistula because that's the only defect. Sometimes we call it an H type because it looks kind of like an H. Is that right? H type. But these are a little bit more rare. What's the most common cause of esophageal, congenital abnormality? It's actually a combination of these two. All right. So you have your tube, which is good. You start to form your trachea, which is also good. And then for some reason or another, the top of your tube will close. All right, we said it's a combination of both of these. Well, the closure is the esophageal atresia part. And then, after you made your trachea, it won't branch off. That's the second part. So you have a combination of the two. You have the atresia plus the TE fistula. What do you think we're going to call this? We're going to call this esophageal atresia with a distal fistula. And that is the most common. What are some signs? Well, you're going to try and feed, and it's going to hit that blind pouch and not go anywhere. So the baby is going to spit up during the first feeding, during the initial presentation, because they're born with this. So spit with first feeding. And you might say, what the heck? What's going on? And so you might try and pass the nasogastric tube down, and it won't go anywhere. It'll just coil up in this blind pouch. And then if you take a chest x-ray, you'll just see that coiling of the nasogastric tube. So you'll see nasogastric tube in pouch. Something else you can find on x-ray. We're just talking about your esophagus. Let's talk about your trachea. If you take a deep breath in, all that air will go to your lungs, which is good, but because you have a fistula, some air can also go down into your tummy. And so you're gonna see a lot of gas in your stomach. That's not normal. So chest x-ray will show gas in the stomach. Got it? One more thing you should know. Once you fill up that gas, or once you fill up your stomach with gas, then it kind of displaces that acid, and that acid can go up and go into your lungs, and your lungs will freak out. They'll start to spasm. We call that laryngospasm, and your baby can stop breathing or be cyanotic because your freaking airway is spasming. So laryngospasm, stenosis. A lot of complications that can go on, and you should be able to recognize this. If it's really severe and it really happens early on in utero, then you can get polyhydramnios. Why do you get polyhydramnios? If you remember from our repro block, the fluid in your belly when you're pregnant is just kind of baby urine. And the way you recycle that fluid is you swallow it. All right, that reduces the fluid. And the way you make more fluid is you pee it out. If you can't swallow the fluid because you have a blind pouch, then you can no longer reduce the fluid level. So you just get buildup fluid, and you get polyhydramnios. And that's your esophagus. Let's move on down. So we're moving on down the esophagus. What's the next thing? We have our stomach. And the stomach, we said, had a little outlet called your pylorus. You can have something called pyloric stenosis. What do you think that is? What do you think that is? The name gives it away. This is when your pylorus is a little too tight, or you can have hypertrophy of the muscle. It usually doesn't present right away. Usually fine, you're usually able to eat, but as weeks go on, the muscle will continue to hypertrophy until it's so tight that food can no longer pass, and the food will build up and build up and build up until your baby projectile vomits, like projectile. So all right, projectile vomit. They might ask you, anytime a baby throws up, you want to see if it's bilious or non-bilious. That means, does it have bile or no bile? This is going to be non-bilious. Why is it non-bilious? Because bile is released in your duodenum by your gallbladder. If food never gets to your duodenum, then will it ever touch bile? Will there ever be bile in your vomit? No. Yes, never gets to that point. It gets stuck before it hits that, so it'll be non-bilious. That tips you right away that the obstruction is before the duodenum. Dead giveaway. And then they might ask you, what do you expect to find on physical exam? You can actually feel that thick muscle. It'll look like a lump in the stomach. So all right, palpable mass. They might ask you what labs you're gonna find. Same labs as you'll find in anyone that throws up too much. You throw up all those electrolytes. You throw up all that acid, so you'll be metabolically alkalotic because you throw up all the acid, you throw up all those electrolytes, so you're gonna have hypokalemic, hypochloremic because you're throwing up all those electrolytes, metabolic, alkalosis. All right, some risk factors. It seems to happen more in firstborn males. Why? No one really knows. Also, it seems to be associated with use of macrolides, so that's their antibiotics in utero. All right, so firstborn males, macrolides, those are your risk. I think the trickiest part is just to remember that it doesn't present right away. So if someone throws up right away when they're born, it's not pyloric stenosis. Pyloric stenosis, like I said, takes some time for that pylorus to get hypertrophied and tightened. Usually presents around 2 to 4 weeks. All right. So baby's feeding well, and then a month later comes in, doc, my baby's projectile vomiting, and then you're thinking of pyloric stenosis, okay? That is your esophagus, that's your stomach. Let's move on down. Let's talk about your pancreas. How did you make your pancreas again? Can you remind me? We said your pancreas comes from your duodenum. Should I draw like that? I'll draw like that. We said there's a budding that comes out, right? And there's a ventral bud and a dorsal bud. And from the ventral bud, we also said that you have things that made your gallbladder and your liver, but we're not talking about that today. We're just talking about the pancreas. And your ventral bud, we said, will swing back around and connect to your dorsal bud. And that makes your pancreas. And your pancreas, when it's all said and done, actually looks kind of like that, right? Looks like that. There's your uncinate process, uncinate, your head, main pancreatic duct, your body, and then your tail. And what do we say the ventral bud made? The ventral bud swang around and made basically this whole part. So your uncinate, your head, main pancreatic duct. Uncinate or uncinate, head, main pancreatic duct. And then your dorsal bud will connect, especially at the head area, so it contributes to the head. And then it makes everything else, plus everything else. Now, what can go wrong? Well, there's only one real process that can go wrong, it's swinging around. One of the things that can go wrong is that it doesn't swing around properly, and we call that an annular pancreas. What does annular mean? Annular means ring-like. So it'll swing around and actually make a ring around the duodenum. And that's not good, it can compress the duodenum. So I'll say, compresses duodenum. Makes a ring around the duodenum. And if it compresses that, you'll have an obstruction. Food will come down to your duodenum and won't be able to go any further, and it'll build up and build up until you vomit it. Is it bilious or non-bilious? You tell me. We said that bile starts in your duodenum, and anything before your duodenum won't be bilious. Yeah, it will be non-bilious. Well, this is in your duodenum, so it's going to be bilious. It's going to have that bile, so all right, bilious vomiting. That's it for annular pancreas. Something else you can have? Pancreas divisum. What do you think that means? Judging by the name, that means your pancreas never swings around, never connects, so it stays divided. Divisum. All right, so it never swings around. So you have your two buds separate from each other. And they can still kind of function. Most of the times you're asymptomatic, so I write asymptomatic. But if it's really bad, if it's really severe, then your pancreas can stop functioning, start auto-digesting itself. Chronic pancreatitis. And because you have chronic pancreatitis, you can have chronic abdo pain. That's no good. So it really depends on the severity. So I'll write pancreatitis plus abdo pain. They're not going to expect you to know it from just a history of abdo pain or pancreatitis. And you have to give you like a scan or an image or something, or just straight up tell you that the two things are separate, and then they might ask you, what is it? Pancreas divisum. That is your pancreas. Since we're on the talk of your foregut, now moving on to your midgut, let's talk about your midgut. Your midgut, I said, is a part that comes out of your umbilicus, rotates this crazy thing, and then comes back in. That's a pretty complicated process. You can imagine there's a million things that can go wrong. So let's talk about some things that can go wrong. So midgut. So your midgut comes out, twists around, comes back in, and then your stomach should close itself. Sometimes we call these folds, these lateral folds, and they should close. And if your lateral folds don't close, then your gut can continue to herniate out. So I'll say lateral fold defect, intestines will protrude out. Intestines out. And we're going to talk about this in a little bit more detail in a second, but before we go on to that, sometimes your lateral folds will come together. However, maybe at the bottom it doesn't come together. So it comes together, but at the bottom there's a little opening. And if you put too much pressure on that, then the bottom part will rip open, and other things can protrude other than your intestines. We call that caudal fold defect. Caudal meaning towards the tail, because as an embryo, it's really hard to say superior and inferior. It's more easier to just say towards the tail or towards the bottom. So the bottom part of your fold never closed. All right, so there's like an opening, and that opening ripped open, and some things protruded out of it. Some things that can protrude out is your bladder. We call that bladder extrophy. If there can be a defect on the bottom, you bet there's going to be a defect on top. So we'll say the lateral folds are closing, but at the top, there's a little opening. If you put enough pressure on that, then you can have an opening in the top. And we call that rostral. Rostral means towards the head. Rostral fold defect. Usually, you'll see something wrong with the sternum. There might be like a divot, or it might be a cavity. We call that rostral fold defect. So just write sternal defect. Shows up as sternal defect. All right, so you have to have those folds closing. Let's talk about lateral folds. That's the main thing, because we're talking about GIT. I mean, bladder, you gotta know that. Sternal, you gotta know that. But since we're in the GIT block, let's talk about GIT. When your lateral folds don't close, and the gut that was supposed to come back in and stay there is now able to leak back out. If it leaks back out through the umbilical ring, the umbilical cord, then it'll be covered by peritoneum. We call that omphalocele. Omphalocele. And so you have things. So you have intestines leaking out right in the center, right through the umbilical ring. Sorry, central umbilicus or umbilical ring, covered in peritoneum. Sometimes it cannot be so neat. It cannot go through the umbilical ring. It can go to the side, just kind of blurt out inside, just bleh. And if it doesn't go through the umbilical ring, then it's not covered by peritoneum. Yeah, it's just covered by nothing. We call that gastroschisis. So I said it was lateral and therefore not in the umbilical ring, not through umbilical ring. And because it's not through the umbilical ring, it's not covered by peritoneum. Not covered by peritoneum. All right, but let's say you don't have these. Let's say your midgut comes out, rotates, it comes back and then stays in, your lateral folds closed. All is fine and well, right? Wrong. You can have something else. You can have atresia of your intestines. Atresia meaning they just fail to develop. So you can have duodenal atresia, duodenal atresia. Sorry, duodenal atresia. And we have duodenal atresia, then you have an obstruction. But the thing they like more than anything is to know that it's associated with Down syndrome. D for duodenal, D for Down. And then they might show you an image of it on X-ray. X-ray. What does it look like on X-ray? Well, if we draw this a little bit better. So this is your esophagus, this is your stomach with your pylorus, and then this is your duodenum. Okay? If you have atresia and it no longer develops, and the proximal duodenum will start to dilate, all the way up until it hits your pylorus, and it can't really dilate anymore because it's that thick muscle. And on X-ray, it'll see this dilation and your stomach dilation, and it looks kind of like two bubbles. We call it double bubble. Double bubble. Double bubble. And so the questions I've always gotten is they'll show the X-ray, show these two bubbles. It's very easy to pick it up. Picture below my notes, and then ask, what's the patient likely to have Down syndrome? Okay. Or they might ask you further questions about Down syndrome. So were they at risk for developing when they're older? Things like Alzheimer's. You hear a murmur. What could it be? Probably VSD, because Down syndrome patients have endocardial defects. So again, a lot of ways they can throw it at you, but as long as you know how to identify and know it's associated with Down syndrome, you shouldn't be too caught off guard, okay? That's atresia of your duodenum. Well, there's a lot more to your intestines and your duodenum. How about your jejunum, your ileum. How about those? Can those undergo atresia? Sure they can. Those, I'll just write jejunal, ileo, colonic. Those are less associated with Down syndrome. Those are more associated with vascular accidents. Vascular accidents. This is when it wraps around the mesenteric artery that's supposed to supply it. And then it cuts off blood supply and it no longer can get blood supply and it'll start to die and undergo atresia. So vascular accident. I've seen pictures on it on the real thing. Instead of a nice thick bowel, because it starts to die, it'll look very small and very curly. Sometimes they call it apple peel. Apple peel, because it looks like an apple peel. It looks kind of like that, very curly, very thin compared to the rest of your intestines. Okay, it's thin because it's lacking blood supply. All right, that does it for some pathologies that can go wrong when we're making our gastrointestinal tube. Hope you enjoyed the video. Thanks.